Hello guys, hope I'm audible and visible. Very good evening everyone. So I hope your exams went well and let's start a few fresh discussions for this year. And it's going to be very an impromptu session where I'm not going to discuss MCQs. I just want you to let your imagination flow away and just diagnose whatever comes to your mind, right? So this is about three interesting cases discussion where I'll be having an image or a couple of image. Some of them are from original case series, whichever we have reported in a hospital, and some of them are from Robin's textbook, right? So I want you to diagnose them. I'll give you a little bit clinical history for obviously for everything, and let's discuss something related to that, and let's see if we can make the best out of it, right? And few things to start with. There's a price hike from May 31st, so if you want to subscribe to Unacademy, you can use any code whatever you have, or you can use Pathocups, and you get an offer of 2 months for every 6 months. There's a batch for the next 2023, a NEET or next whatever is going to happen, though we don't know about it, as a free test calendar and a few specific batches for your UPSC CMS and MBBS Prof as well, fine. And that I'll be hosting a special class by 11 tonight. It'll be on lymphomas. We've been discussing lymphomas for FMG practicals, FMG exams for quite some time now. We'll have a few more things based on the same thing at 11 p.m. tonight in the app, fine. Let's go ahead and discuss about the case number one. As I said that this should be interactive, and I want you guys to comment on whatever comes to your mind. There's no inhibition, just comment on whatever comes to your mind. I'll give you just a little bit of information regarding that case, and we'll try to diagnose with IHC or without IHC, and we'll discuss something related to the case which might be helpful for your exams or in your real life, right? The case one, the patient presented with an, let's say, an left-sided cervical lymphadenopathy, right? The left middle cervical lymph node was enlarged in this patient, and with lots of differential diagnosis, they went ahead with the biopsy, and this was the diagnostic field in the biopsy. So comment on whatever you are seeing here. What do you see here? What's the structure seen here? This is a lymph node biopsy, and the lymphadenopathy for the patient was there for the past maybe 6-7 months. There are a few comments here I want you to make. What do you think, whether it's a neoplastic lesion or a non-neoplastic lesion? That's the first question. What do you think about it? Is it a neoplastic lesion or a non-neoplastic lesion? Okay, if it's a neoplastic lesion, I'll circle some things. Tell me what are these cells. We'll go with the normal to the abnormal. Tell me what are these cells. There's a normal component of a lymph node. Comment on whatever comes to your mind. What are these? I'll highlight every important pieces in the diagnostic clue here. That's the first thing which I highlighted. The second thing what I want you to concentrate on these group of cells. If you are concentrating on this group of cells, please look at the color. The color will help me a little bit to arrive at a diagnosis. What do you think they are? If you want, I'll zoom it a little bit. Lots of RBCs and a little bit of cells which are required for me, which is eosinophils, right? So we do have eosinophils, we do have lymphocytes, we have RBCs, perfect Saloni. And tell me, what is this? This is a very classical cell. I thought you guys should have diagnosed just by focusing on this cell. Tell me, what are these? Shumel, this, okay, if it is not a macrophage, if it is a macrophage, should it be single nucleated or multinucleated or have two nuclei? Shumel? Macrophage should ideally have a single nucleus, right? So if you look at that cell which you have circled, and if you look at this cell which you have circled, do they have multiple nuclei or they are binucleated, right? So whatever Saloni said, can it be an outside nuclei? Possible? Maybe, right? So if it is an outside nuclei, what do you think is the diagnosis? I'm having outside nuclei. We are having background lymphocytes and little bit in the corner, little bit of eosinophils, somewhere in the top 12 o'clock field also I'm having few eosinophils. What do you think is the most common diagnosis with these findings? I'll enumerate the findings. I'll write them down as well if you guys want. I'm having background inflammatory infiltrates, which is composed of lymphocytes and a little bit of eosinophils. I'm having query outside nuclei. I'm not sure whether it's an outside nuclei. I'm having query outside nuclei. Okay. So with the outside nuclei, Saloni is going for an cytomegalovirus, right? If you have a cytomegalovirus, should that be an inclusion body or not? Should a cytomegalovirus have an inclusion body? Okay, second one, Dr. Manish has gone with Hodgkin's lymphoma. Can it be in Hodgkin's lymphoma? This outside appearance doesn't mimic an Hodgkin's lymphoma because the background lymphocytic infiltrate and eosinophil is definitely suggestive of Hodgkin's lymphoma. My only question is, will the outside mimic an RS cell? Do they mimic an RS cell? They do kind of mimic an RS cell, right? So I do have something like an RS cell. But if you have seen a classical outside appearance, classical Hodgkin's lymphoma's RS cell, the cytoplasm will generally not be clear except for in one variant. So if I want to name this type of RSL, which RSL you will name? I'm having a perfect, if not perfect, I do have an outside nuclei here. I'm having good amount of clear cytoplasm. So which variant of RSL will fit into this? Nucleoli is eosinophilic, for sure, Dr. Manish. Which variant of RSL will have this clear cytoplasm? That's a very particular variant that actually gives me the sub-diagnosis also. You must have heard about lacunar, perfect, right? You must have heard about lacunar variant of RSL, right? So if I assume that this is a lacunar variant of RSL, what type of Hodgkin's lymphoma I'm suspecting? Classical Hodgkin's is still, you can fine tune your diagnosis. It's not just classical Hodgkin's. There's one variant of classical Hodgkin's which will have lacunar variant of RSL, which subtype? In other words, is it nodular sclerosis, mixed cellularity, lymphocyte predominant, or lymphocyte depleted? Which will have your lacunar variant of RSL? It will be nodular sclerosis, right? So nodular sclerosis will have a lacunar variant of an RSL. So we have a suspicion of a nodular sclerosis, right? So again, like you guys said, it still can be a macrophage. I don't know. If it's a neoplastic macrophage, it can be multinucleated, right? It could still be any other thing. So to prove for our suspicion of a nodular sclerosis variant of Hodgkin's lymphoma, lymphocyte predominant will not have this lacunar variant. Nodular sclerosis generally has the lacunar variant, fine. Again, as you can see, I do have few eosinophils. So my diagnosis of lymphocyte predominant will not be fitting into this case, fine. Lymphocyte predominant NLPHL, nodular lymphocyte predominant Hodgkin's lymphoma, what type of RSL will they have? And Saloni has thought about NLPHL. What type of RSL will NLPHL have? They have something called a popcorn variant of RSL, which is nothing but I'll have an indented cleave nuclei with a nucleoli, right? I'll have a popcorn variant, not a lacunar variant of RSL. Lacunar variant is seen in a classical Hodgkin's lymphoma, your nodular sclerosis, right? So, like I said, I might have few differential diagnoses for the same thing, for the lacunar variant of RSL. So, if I have to prove it's an RSL and a Hodgkin's lymphoma, what immunohistochemistry marker will I require? That's my first question. Name any IHC which comes to your mind. You have to diagnose a classical variant of an Hodgkin's lymphoma. There are two IHCs which is must to diagnose classical variant of Hodgkin's lymphoma. Perfect, Saloni. I'm going to think of an 15 and 30, right? Great. Just erase this. See, when it comes to immunohistochemistry, the first few things you have to remember is I have to identify what type of lymphoma it is first. For a Hodgkin's lymphoma, I have two broad variants of classical Hodgkin's lymphoma and nodular lymphocyte predominant Hodgkin's lymphoma. Like you guys said, Manish, 45 might not be positive in a classical Hodgkin's. It's going to be predominantly 15 and 30, which will be positive in a clear-cut case of a classical Hodgkin's lymphoma. I'm not just going to leave with that. There is one more marker which is actually very much helpful in diagnosis of classical Hodgkin's. What is it marker? Apart from 15 and 30. Like you guys already know, NLPH is negative for CD50 and CD30. They're negative, but they're positive for CD20 and CD45. I'm not asking that. I want one more marker which will help me to diagnose it as classical Hodgkin's. Actually, that marker will be weakly positive in case of classical Hodgkin's. Classical Hodgkin's, what marker is that? No, 20 will be negative in case of classical Hodgkin's. What marker do you think will be positive in case of a classical Hodgkin's and it's weakly positive? That's very, very characteristic for the tumor. It is PAX5. PAX5 should be weakly positive. If PAX5 is strongly positive, it is not a case of a Hodgkin's lymphoma, classical Hodgkin's lymphoma. It has to be weakly positive because PAX5 in real life is a B cell marker. And it said that do remember this. These are exact words from WHO. Hodgkin's lymphoma arises from a crippled B cell. It's not actually arising from an exact B cell. That's why a classical Hodgkin's lymphoma does not express CD20. Though we classify them under a B cell neoplasm, it doesn't express the classical CD19 and 20. It expresses a weak PAX5. It's a crippled B cell. It's a dying B cell which is being pushed with your EBV induced proliferation, and it becomes a neoplastic proliferation, right? This is very, very classical for a classical Hodgkin's lymphoma. For NLPHL, it will be strongly positive. 20 is positive, it's a B cell marker as well, fine. Okay, so we did go ahead and we did CD15. This is the image of CD15, positive or negative. The CD15 IHC, these are positive or negative? They're undoubtedly positive, right? The interpretation of immunohistochemistry is same across the body. If I have something brown in color, it is positive. If it is not brown in color, it is negative. In this image, all these areas where I'm not seeing any brown color, all these areas are negative, right? All the areas in the background are negative, only few cells are positive here. That again reiterates the fact that in a Hodgkin's lymphoma, the tumor cells is not the predominant population. I do have a good amount of tumor cells there. At the same time, there's lots of background inflammatory infiltrate which will not be positive for CD15 or CD30, right? This was CD15 and it was positive. It's actually, it is reported as an, as you guys said, nodular sclerosis variant of a classical Hodgkin's lymphoma, right? Great. Let's go to few MCQs with relation to Hodgkin's, right? Because since our focus is going to be predominantly for an competitive based exam, we'll cover them as well. We know to diagnose, at the same time we should be able to clear the exam as well, right? The first thing, which subtype of Hodgkin's lymphoma do you think is the commonest variant in our country and in the world? Unfortunately, I do need to differentiate them. Hopefully, India will improve statistics and will not have such problem in future. The most common variant of Hodgkin's lymphoma in the world, it's nodular sclerosis. The most common variant of Hodgkin's lymphoma in our country, it's mixed cellularity. Actually, in our country also, it's slowly moving towards mixed cellularity. Unfortunately, we still have to reach this difference. Hopefully, it will nullify in future. Fine. The reason why the Western population is having more case of nodular sclerosis is it's EBV negative. The Western population, they say in a very well-developed country, the risk of infection is a bit more. They are mostly negative for EBV, and it's still told in a third world country where I'm not going to have such a good socioeconomic development. It is still positive in our country, EBV, so mixed cellularity is a little bit more. It's a little bit biased, fine. Second, when I say it's a Hodgkin's lymphoma, tell me the Hodgkin's lymphoma in total with best prognosis. Which group of Hodgkin's lymphoma do you think will have the best prognosis? Which subtype? Which subtype will have best prognosis? It's obviously your NLPHL. The best will be NLPHL, then comes your nodular sclerosis, then comes all the mixed cellularity, lymphocyte predominant and lymphocyte rich and lymphocyte depleted in that order, right? The best prognosis is lymphocyte predominant. Please do not confuse lymphocyte predominant Hodgkin's lymphoma from lymphocyte rich variant of classical Hodgkin's lymphoma. When you say lymphocyte predominant, it is non-classical Hodgkin's lymphoma. That's a very subtle difference. One is lymphocyte predominant, one is lymphocyte rich, right? Third, which of these two classes of Hodgkin's lymphoma I can give rituximab as a part of therapy? Which type of Hodgkin's lymphoma rituximab can be given as a part of therapy? Rituximab can be given only for NLPHL. It cannot be given for a classical Hodgkin's lymphoma, right? Because classical Hodgkin's lymphoma are negative for your CD20, so rituximab is not going to work for a classical Hodgkin's lymphoma, right? Fourth, Hodgkin's lymphoma can involve the Valde's ring. True or false? This a general difference, maybe clinical difference between Hodgkin's and non-Hodgkin's. Can Hodgkin's lymphoma involve the Valde's ring? That's the first question. Can Hodgkin's lymphoma involve your mesenteric lymph nodes or an intra-abdominal lymph nodes? That's second. These are all interconnected, right? Because clinically I should be able to differentiate, have a little bit of suspicion between a Hodgkin's and non-Hodgkin's. Hodgkin's rarely involves your Valde's ring. It's going to be extremely rare involvement of Valde's ring or your mesenteric and intra-abdominal lymph node. I'm not saying it never involves, it's extremely rarely involves, right? It generally involves a single group of lymph nodes, cervical, mediastinal, or aortic, aortic, only single group, right? And they spread by contiguity. They spread to slowly, right? When they spread by contiguity in the sense, this is very, very classical for a Hodgkin's lymphoma. If I'm going to have let's say this clavicle and your sternomastoid, I'm having upper, middle, deep cervical lymph node. It spreads from this to this. That's contiguity. From upper cervical, middle cervical, and deep cervical. It might not jump from my upper cervical to axillary. That's why it said that it involves a single group of lymph nodes, generally cervical, and your Valde's ring and mesenteric lymph nodes are rarely involved in Hodgkin's lymphoma, and all these are much more common in non-Hodgkin's lymphoma. Fine. A few things regarding Hodgkin's. We saw a case of Hodgkin's, and you guys were good enough to diagnose that. Fine. So let's go and have a second look. These are images from Robbins, so it's not my case. I do have a few more cases down the road. We'll see. The case from lesion on the hand, right? This was the gross image. It's been excised. Let's say it's from the phalanx. This tumor has come outside, right? Tell me, what are the differential diagnoses looking at this image? You have a very classical image. It's a finger lesion. What all comes to your mind? You can tell whatever comes to your mind. Maybe right, maybe wrong, doesn't matter. Anything which comes to your mind. It's first, is it neoplastic or infectious, inflammatory? Okay, Manish has gone directly to the diagnosis. I expected few of the differential diagnosis before jumping into a correct diagnosis, right? First thing for me, it's a neoplastic lesion, right? So it's an hemorrhagic neoplastic lesion. When you have so much good amount of hemorrhage, osteosarcoma, GCT, perfect. Those are my differential diagnosis I wanted. Fine. Your diagnosis is correct, but I do want a little bit of differential diagnosis to play around with. I can think of a neoplasm. That's my first thought. It's not an infectious condition, obviously. I won't have a defined tumor like that if it's an infectious and inflammatory condition. Then let's take osteosarcoma, let's take GCT, and let's take whatever Manish said, Brown's tumor. Okay. I said it's a lesion in the hand. Is there a possibility of an enchondroma in this image? Is enchondroma possible? Not possible at all. I'm just asking, can I keep them in the differential diagnosis? May not be the right answer at all. Keep enchondroma. So I will not think of an enchondroma here. I'll tell you the reasons. Enchondroma, first of all, why I am not going to think of primarily is, it will not be so hemorrhagic. If you look at this lesion, yes, you can see the phalanx here, maybe the bony part. The entire lesion is fully hemorrhagic. Right? If it's an enchondroma, it might not be hemorrhagic, as I said. The classical finding which I'm going to see in an enchondroma is a glistening appearance of a cartilage. I can tell it's a procedural hemorrhage, but still, even if it's a procedural hemorrhage, even the locules, what I see here, will not be red in color. I might have ill-defined procedural hemorrhage. It's unlikely to be an enchondroma, which will be white in general, and it will be glistening. Enchondromas are rarely hemorrhagic. The cartilage appearance can be easily picked up on an enchondroma, right? Second, osteosarcoma. I said it's a lesion in the hand. How common do you think osteosarcoma is in the hand? Is it common or is it rare? It's not that common, right? Osteosarcomas of the hand are not that common. It's a bit rare finding, right? Even if it's osteosarcoma, if it is osteosarcoma, what type of osteosarcoma can have this appearance? If it's osteosarcoma, I want it in the subtype, because not all osteosarcoma can have this appearance. One type of osteosarcoma can have this appearance. If so, which type is that? Which subtype of osteosarcoma? You must have read them in orthopedics. Perfect. It could be still telangiectatic variant of osteosarcoma. Right? Telangiectatic variant of osteosarcoma can be very much hemorrhagic, which might confounding factor sometimes in diagnosis. In a microscopy also, it's not that easy to pick up a telangiectatic osteosarcoma in a core needle biopsy. Excision is very, very simple, right? But unfortunately, telangiectatic osteosarcoma is one which can spread a lot. They have very high incidence of metastasis. They generally present with metastasis rather than the primary tissue, right? Giant cell tumor. Again, is it common to have a giant cell tumor in the finger? It's not common to have the giant cell tumor in the finger. But one thing which is perfectly matching the giant cell tumor is the multiple loculated appearance with good amount of hemorrhage. Both of them will be fitting into the description of giant cell tumor, plus the expansion. If you look at this, can I say definitely this tumor is expansive? It's definitely expanded, right? It's expanded the cortical thing, and it's expansive, it's hemorrhagic, it's multiloculated. So looking at the gross appearance, if I don't have the history of a lesion in the hand, I would first probably think of a giant cell tumor, right? So let's say that these two are my close differential diagnosis: a Brown's tumor and giant cell tumor. Which condition do you see Brown's tumor? Where do you see Brown's tumor? You see Brown's tumor in one particular condition. Which condition is that? You see them in hyperparathyroidism, right? There's a classical tumor seen in hyperparathyroidism. If it is a Brown's tumor, what do you see in microscopy? If it's a Brown's tumor, what do you see in microscopy? If it's giant cell tumor, what do we see in microscopy? Based on that, let's see the microscopy soon and identify what it is. Brown's tumor will have a classical finding of burrowing of the bony trabeculae. That's very, very classical of Brown's tumor. Okay. So what happens is, in a hyperparathyroid patient, there's going to be more amount of mobilization of the calcium from the bone into the serum. That's what is going to result whenever the parathormone is more, right? So if I'm having let's say a bony trabeculae is like this, normally a bony trabeculae is like this. In Brown's tumor, what will happen is it'll be burrowed. It'll be burrowed by lots of osteoclast, because the resorption pits becomes more active, more in number, and more deep than in a normal person. Right? It keeps on burrowing them. This burrowing appearance of a trabeculae is very, very classical for a Brown's tumor. That will easily fetch me the diagnosis in a microscopy. I will have other features of hyperparathyroidism, hypercalcemia, your bone pain will be there, your abdomen pain will be there, you might have renal stones. That will be surrogate findings to say me, okay, this is definitely a systemic disorder and hyperparathyroidism, right? GCT. GCT is a classical appearance. What do you see? What will you see in microscopy of GCT? GCT is a very, very classical appearance. It is abundant number of giant cells, multinucleated giant cells. It's not just the multinucleated giant cells, plus they have lots and lots and lots of stromal cells. They are both good amount of giant cells as well as good amount of stromal cells, right? So of these two, I know that's a repeat question what I'm going to ask. Which of these two do you think is malignant or neoplastic? Which of these two do you think is neoplastic? Your giant cell or stromal cell? Stromal cell is a neoplastic component. Do remember them. Giant cell is not the neoplastic component. This is a repeat question. I'm sure you know that, right? Giant cell is a reactive component. Do remember, Shamil, giant cell tumor is a misnomer. Osteoclastoma is a misnomer. Giant cell is a reactive component here, and the stromal cell are the neoplastic component in a giant cell tumor. Do remember them. And giant cell tumors will not have bone. It's completely will be eroded, destroyed. It's more of a solid soft tissue lesion. Fine. Okay, great. So we had these two differential diagnoses. Let's go to the microscope. As I said, there's a classical image from Roberts. So which do you think fits into the diagnosis? Giant cell tumor or your Brown's tumor? We discussed both of them. Which you think will be a perfect match here? Obviously, it's in giant cell tumor. Brown's tumor, right? Obviously, it doesn't fit into a giant cell tumor. It's obviously burrowing appearance is there. It's a classical case of a Brown's tumor. Fine. Great. Okay. You go to the third case. This is a post-mortem case. Fine. These are maybe two images clubbed together. Let's see if you can come to a diagnosis. Fine. A post-mortem appearance of a patient. This is the post-mortem organ. First, tell me what organ it is. That's a very, very easier one to pick up. No, Shomel, it's in reactive conditions seen due to hyperparathyroidism. That's all. Right. So it is, once I am going to treat hypercalcemia, the activity of the parathormone stimulated osteoclast will reduce. So it can revert back to normal if sufficient damage is not done. Right? Okay, perfect. That's a kidney, right? So looking at the kidney, tell me what do you think is abnormal? What looks abnormal at the first sight? Great. Can I call it the kidney is dilated? It has, it is dilated, right? The pelvic caliche system is dilated. Like I should have said, this could be a classical case of an hydronephrosis. HDN stands for hydronephrosis, I hope, right? So definitely a dilated pelvic caliche system and a classical case of an hydronephrosis, fine. So if I have hydronephrosis, be it clinically or be it post-mortem, I have to differentiate. I have to know the cause because hydronephrosis is not a disease. It's an effect of some other disease. Unless and until I'm going to treat the other disease, I cannot take care of this, right? So when I have hydronephrosis, there are two. One of the pressing things for me is I need to know whether it's unilateral or bilateral. Because if I know it's unilateral or bilateral, there are few causes which can be ruled out and few causes which can be ruled in as well based on this the site, right? So if you think you have a bilateral hydronephrosis, what all differential diagnosis will come to your mind in case of bilateral hydronephrosis? Bilateral hydronephrosis, what are the things which comes to your mind? Anything when the block is below your bladder, I'm going to think of a bilateral hydronephrosis. Bladder and below. If it's an urethra, I'll have bilateral hydronephrosis. Bladder, I'll have bilateral. Prostate, I'll have bilateral, right? If it's bilateral, it should be either below your bladder. It can be some problem in the prostate. It can be some problem in the urethra. If it's a kid, I would think of a posterior urethral valve. Posterior urethral valve will also block the urinary flow. Over the period of time, everything is going to result in your hydronephrosis. Prostatic cancer, yes. Bladder outlet obstruction can be due to prostate cancer, can be due to your urothelial cancer of the bladder. It can be due to bladder calculi as well, right? It can be. Bilateral vesico-urethric reflex is a possibility, but it's not very common to have bilateral. Unilateral is a bit more common. So these are the possibilities if I have bilateral vesico-urethric reflex that can also lead to a bilateral hydronephrosis. More than that, it might lead to your chronic pyelonephritis more than hydronephrosis, right? If it's a unilateral hydronephrosis, see, unilateral hydronephrosis has much more differential diagnosis than bilateral. What do you think are the causes of unilateral hydronephrosis? Any cause of unilateral hydronephrosis? One, I can have a block at the site of pelvis. If pelvis is blocked, the renal pelvis, if it's blocked, I'll definitely have a problem. It could be as simple as, like I should have said, it could be as simple as a calculi. It could be a PUJ obstruction. That's also possible, right? So it could be your tumors in the pelvis. You can have calculi in the pelvis. You can have tumors in the pelvis, right? So if it's a calculi obstructing the renal pelvis completely and causing an hydronephrosis, what type of calculi do you think it will be? Because not all calculi can obstruct the entire pelvis, right? There are few calculi which have the capacity to do that. What calculi do you think it will be? What calculi do you think it can obstruct the entire pelvis? You must have heard about Stackhorn calculi. Stackhorn calculi is one which can entirely obstruct the renal pelvis and can cause an hydronephrosis. Other types of calculi are generally very tiny. It might cause an obstruction when it's stuck in the ureter, not in the renal pelvis. Fine. Just two ways shows the Stackhorn calculi can causes. I can have obstruction if you have any problem in the ureter as well. Fine. If you have any problem in the ureter, here also it can be calculi. It can be tumors. It can be any inflammatory condition, or if a sloughed off papillae. If I'm having a renal papillae which is getting sloughed off and it's obstructing my entire ureter, that also can cause an hydronephrosis. There are a few other possibilities of unilateral hydronephrosis, which is extrinsic. I want you to think widely and come to an answer. What are the extrinsic causes of unilateral hydronephrosis? Which means it is not related to my renal, ureter, and your bladder system. It's something outside the ureter, something outside the scope of kidney. Any extrinsic cause which comes to your mind, which can cause unilateral hydronephrosis? Or it might sometimes compress bilaterally as well. Anything which comes to your mind? Great. I can have tumors outside the kidney compressing them, right? That's one for sure. If there's a retroperitoneal liposarcoma, it can compress. A carcinoma cervix going up and spreading, it can compress, right? Anything apart from tumors. You're totally dwelling with the help of cancers, right? Anything apart from that? Can a simple pregnancy cause hydronephrosis? It can, right? A simple pregnancy, when the size increases, it can easily cause a compression of the ureter, right? It can cause hydronephrosis, right? Third part, I'm sure you must have heard about a disease called as an idiopathic retroperitoneal fibrosis. Have you heard them? Idiopathic retroperitoneal fibrosis is one of the classical things presenting symptom could be an unilateral hydronephrosis. You must have heard that, or it's called as an hormones disease, an idiopathic retroperitoneal fibrosis. We have reclassified this disease as of now, as of today. How have we reclassified the disease? It's not anymore called as idiopathic. You know the reason now. We have reclassified this idiopathic retroperitoneal fibrosis into what group of disorder? We have reclassified them into IgG4 mediated nephropathy, inflammation, right? We have a group of IgG4 mediated disorders. Hormones disease, idiopathic retroperitoneal fibrosis, as on date, is an IgG4 mediated pathology. Fine, great. So this was a postmortem finding. In the same image, postmortem also had this. So what organ is this? Comment on the pathology and how is it related to the kidney picture? It's a urinary bladder, right? And the urinary bladder has a perfectly defined carcinoma. It's almost filling the entire bladder except for this part where I can see a tiny outlet, but rest everything is filled by a cancer. So this could have caused bladder obstruction. Because of the bladder obstruction, the patient would have presented with an hydronephrosis, right? It's just two images to link and to come to different conclusions and different differential diagnosis. Fine. Okay, let's go to the next case. This is also image from Robbins. Let's see if we can pick it up. It's a patient with I'm going to twist the history a little bit so that we'll have more scope of discussion. The patient, 34-year-old person or 44-year-old person, presents with menorrhagia, and hysterectomy was done, and this was the finding seen in the uterus. The first comment on the gross appearance of the uterus, then we'll go to the microscopy for sure. 44-year-old person presented with menorrhagia, and this is the finding seen in the uterus. What all comes to your mind first? Tell me the differential diagnosis. I don't want one correct diagnosis. I want differential diagnosis. You might be correct, but the entire scope of discussion is to discuss and let your mind go wherever it can. We'll divide the same thing. Inflammatory, neoplastic. Inflammatory or neoplastic? Okay, both of you have commented as endometrial carcinoma. So you presume you have gone for neoplastic, right? Let's assume it's neoplastic, right? If it is neoplastic, okay, Saloni has gone for endometriosis. Malik has gone for fibroid. It's neoplastic, right? Okay, let's say we do have more votes for neoplastic, so I'll consider as neoplastic. It's unlikely to be an inflammatory condition because I don't remove an uterus for an inflammatory condition. That itself says it's something of a neoplastic condition, right? Okay, if it is neoplastic, next question for me is benign or malignant. Malik has given us a differential diagnosis of fibroid. Few of you have given a differential diagnosis of an endometrial carcinoma. So do you think it's benign or malignant? With this image alone. I want you to substantiate whatever you call benign or malignant. I want you guys to substantiate that. Malignant. Why malignant? Why did you call them malignant? Again, don't give the same reason that they remove the uterus. They remove the uterus for uterine fibroid also, right? Why do you call it malignant? Why did you call it malignant? You told it's malignant. I do accept it's malignant, but why malignancy? Okay, Shomil, something red in color doesn't mean it's malignant, right? And hemangioma can be completely red in color. Great. So whatever Aishwarya said is much more confirmatory for me and much more scientific for us, right? If you can look at this, what is this? This is nothing but my myometrium, right? It's myometrium. So this part is myometrium. This part, let's assume it is endometrium, right? So here it has gone into the myometrial wall, right? Has it invaded the myometrium? It is definitely invaded the myometrium, right? That's one classical finding for me, right? It has invaded the myometrium. It's spreading. So if it's spreading, there is most likely to be an malignancy rather than a benign condition. If you can carefully observe, can I say it is also crossed the uterine surface serosa? Kind of going outside as well, right? It's jutting outside and going outside. So it's unlikely to be a benign condition. It's unlikely to be a benign condition. Let's assume it's malignant, fine. So I kind of ruled out many things. So I'm going to think of a malignancy here. So if you're going to think of a malignancy in an uterine tissue and a hysterectomy sample, what do you think will be the differential diagnosis? And I want you to tell why the differential diagnosis. It is malignant. Why? What's the differential diagnosis and why? I would still take endometrial carcinoma, but there are a few things which is against for me for endometrial carcinoma. Endometrial carcinoma will not be so hemorrhagic. It will be necrotic, but not so hemorrhagic, right? So I'll keep endometrial carcinoma down the road. Can you name any lesion which can be extensively hemorrhagic like this? Or it's looking like brownish black color, right? Any lesion which comes to your mind which can have a reddish to brownish to black color in the uterus. I'll ask you a differential diagnosis. Tell me, is it possible? Great. Good, Manish. Good. Can it be melanoma? Can it be a melanoma? Melanoma in the uterus is an extremely unlikely phenomenon, so I'm going to rule that out. We'll take whatever Satyam said, leiomyosarcoma. See, only one thing for me which is against for a leiomyosarcoma is this lesion appears to arise from this area and then appears to go inside. If it's a leiomyosarcoma, it should have come from the wall and should have come inside, right? It looks otherwise, it's kind of invading and jutting into my myometrium, so it's unlikely to be leiomyosarcoma. Chocolate cyst is something which is seen in the ovaries, right? When ovary has endometriosis, I call them a chocolate cyst. Can this fit into a description of a choriocarcinoma? Hemorrhagic, red, and they are notorious to spread and so invading, right? Let's look at the microscopy. Now, looking at the microscopy, tell me, do you want to change your diagnosis or you want to fit into whatever you call? The microscopy, there are a few classical findings here for me. One, having lots of blood. You have RBCs. That's the first finding for me. Second, I do have lots of ugly looking cells, right? Some of them are multinucleated as well, right? They are very ugly looking cells. We have lots of pleomorphic cells, lots of hemorrhage. That's what I told as an RBC. So this is a classical example of an choriocarcinoma. This image is from Robbins, a classical example for a choriocarcinoma. If I have to do one IHC marker to prove it is choriocarcinoma, what marker will I do? Does anything cross your mind? If I have to diagnose the choriocarcinoma, what marker will I do? Anything? Beta HCG, right? So beta HCG can be used as a tumor marker, as well as beta HCG can be used as a serum marker for choriocarcinoma, right? So choriocarcinoma is an extremely fast spreading tumor. So you have to treat, you can give chemotherapy. Obviously surgery will be first line. Give chemotherapy if it has already metastasized. What is the most common organ to which choriocarcinoma can undergo metastasis? That's an MCQ. We'll end this case with an MCQ. The most common organ is going to be lungs, right? It can commonly spread to the lungs. That's one of the commonest site of choriocarcinoma metastasis, right? Great. Okay. Next case. Here I'm going to have 3 images. I will again the same thing we're going to do. I'll show you the gross image first, then we'll go to the microscopy. Fine. First gross image. The rules are the same. Tell me what organ or site is this first, then we'll go to the next. What organ or what site is that first? Cerebellum, great, right? Venous cerebellum brainstem, great. So one thing which I'm sure all of you are comfortable with this is to identify the cerebellar hemisphere, and you guys said it's a cerebellum, right? Okay, I'll go to it. I'm having a lesion, but let's assume that this part is a lesion here, fine. I'm not giving you the age group here, just cerebellum. That's surface of cerebellum. I'm having a tumor which is this big. Tell me your differential diagnosis for cerebellar lesions. Any disease which comes to your mind when you think of cerebellum? Neural nodule. Anyone else? Cystic. Can I call it cystic? Does it really look cystic? Or it looks solid? I know you know the diagnosis. I'm not coming to the diagnosis. I just want us to discuss a little bit more before arriving to a diagnosis. It's juvenile pilocytic astrocytoma only. I just want to discuss before coming to a diagnosis. I'm not going to call it a completely cystic lesion, right? It's more of a glistening thing. If it is eroded completely, maybe I'll call it a cystic, but now it's more of a mucoid lesion, a solid lesion most probably, right? It's not a tumor based, but maybe a mucoid jelly-like matrix predominant lesion, fine. One thing which might be against one more tumor, which also happens in the cerebellum, which also happens in the same age group, the children. Can you anyone name the other tumor which happens in the cerebellum and in the same age group? There's one more tumor which is common in the cerebellum and it's common in the same age group. Hemangioblastoma is will not have this appearance, right? It will be totally different. Okay, hemangioblastoma. It's not a hemangioblastoma. There's one more thing which is medulloblastoma. Medulloblastoma can also happen in the same age group, same site. The point with this tumor, which is against my medulloblastomas, it is well defined, right? It's extremely well defined mass. If you look at this, defined mass. If I want to excise, I can excise the entire tumor just like that, right? It's looking like a perfectly defined mass. Juvenile plasmacytic astrocytoma is a very, very well defined mass. The benign lesion, it can be a combination of cyst and solid. It's not always a stick lesion. It's not completely solid lesion. It's a combination of stick and solid lesion, right? This is a low power image where you can see the matrix. These are all the matrix material. It's a bit loose matrix, and I can see the cerebellum on the outer aspect. If you remember your MCQs which came in anatomy of your cerebellum, you can see the layers of cerebellum there, right? And when you go to the higher power, what are the findings seen in the higher power in case of a JPA? There are a few classical findings which can be seen in case of juvenile plasmacytic pilocytic astrocytoma. That's seen here actually. This is a finding seen there. This is a classical Rosenthal fiber, right? The classical Rosenthal fiber, it's a fiber. If you can see here also I have that, right? It's a Rosenthal fiber, the fiber. It's nothing but GFAP. They're nothing but glial fibrillary acid protein, which is being condensed and in the form of fiber. Fine. There are two classical findings which are seen in JPA. One is Rosenthal fiber, like all of you guys knows. See, when I take a Rosenthal fiber, let's assume this is a Rosenthal fiber. It's like this. It's like a corkscrew, like an arrangement of an GFAP, right? If I have a Rosenthal fiber like this, and if I'm going to cut like this, I will not see the longitudinal one, right? I'll just see the cut surface. So I have two findings. Please do remember both the findings. The cut surface will look totally different. So this might be a Rosenthal fiber. The same thing on a cut surface, we call it an eosinophilic globular bodies. Same thing. It's a different appearance, this different view, that's all. Okay. The eosinophilic globular bodies and Rosenthal fibers both are classical findings seen in juvenile plasmacytic astrocytoma. It's a grade 1 tumor or a grade 3 tumor. WHO generally divides your CNS tumor as per the grades. JPA is a grade 1 tumor, right? And both of them are positive for GFAP, glial fibrillary acid protein positive. If it is a medulloblastoma, right? If it's a medulloblastoma, will they be positive for GFAP? Will medulloblastoma be positive for GFAP? No, medulloblastoma is a neuronal tumor. It's not an astrocytic or a glial tumor. That will not be positive for GFAP, right? Great. Okay. I'll ignore this. I want to go to some few simple cases. I'll take this. This case will have a little bit more scope for a discussion. This is a real case rather than having images from Roberts. Fine. Okay. I'm not going to give you history here. I want you to look at. There'll be two peripheral smears, two hematology cases, and I want you to diagnose everything based on whatever comes to your mind. There are very few things in hematology. Either it could be neoplastic or it's non-neoplastic. If it's neoplastic, leukemia or a lymphoma spillover. If it's leukemia, lymphoid or myeloid. Acute or chronic, that's all. Fine. Let's see if we can come to a diagnosis. Neoplastic or non-neoplastic, if you choose any of them, I want you to substantiate why neoplastic. If not, why non-neoplastic. Comment on whatever comes to your mind. Comment. I thought this is an easy one. You guys were commenting left, right, and center for an histopathology. Hemat is your favorite topic, right? Okay, I'll focus a few things. Tell me what they are. Let's assume this. It's neoplastic. Fine, great. Two of you have commented neoplastic. Why did you comment neoplastic? I want more answers from you so that if our thought process is wrong at some point, we can change that. What is this? Okay, I do accept it's neoplastic, but why did you guys say it's neoplastic? Like in other places, you gave an explanation of saying that in the uterus, it was invading and everything, right? Okay, Saloni has gone one step higher and call it an AML. To call it an AML, you must have seen some cells, right? What are they? Okay, great. I just wanted what Shumel said. I'm looking for blast cell. It looks like a blast. Fine. So I presume that these two, maybe these are the four cells which kind of looks like a blast. Yes. Maybe. I'm not sure whether it's a myelocyte or a metamyelocyte. I'm just saying these are the four cells which looks like an immature cell, right? What made you think of an immature cell? Whatever I have ticked. What made you call them an immature cell? What made you call them an immature cell? You call them an immature cell, maybe due to some reason which an instinct which made you to call an immature cell. I just want you to tell why. Chromatin. I have something which is more important than chromatin here. I do accept it as an opened up chromatin. We'll come to that soon. Nuclei. More nuclear material. Perfect. If you are going to talk about hematology, talk about blast, the first thing I want you to comment on is size. The size. If it's a lymphocyte, it will be the size of an RBC. All the cells here, what I've ticked, it's easily like 3, 4, even 5, 6 times the size of RBC. It's definitely higher. If it's more than 2 times the size of RBC, I'm going to think of some immature cell. If it's lymphoid, myeloid, 3, 4 times more than the size of RBC. Second, like Satvik said, that they do have a high nuclear cytoplasmic ratio. Definitely it's there. Right? That's one. And I have a high NC ratio. Okay. So now I am sure it's a blast. So that was the first step. It's a blast. So I do think it's some of the neoplastic origin only. Fine. So now if I know it's a blast, I need to differentiate whether it's a myeloid blast or a lymphoid blast. What comes to your mind looking at this? Myeloid or lymphoid? Anything which comes to your mind immediately looking at these? Myeloid or lymphoid? Nothing? Nothing strikes? It's a myeloid blast, right? Why did you say myeloid blast? Again, for me to differentiate between myeloid and lymphoid blast, I have to look at the nucleus. Please don't look at anything else. Please don't look at the granules. Granules is important for me. First thing for me is to look at the nucleus. Whether the nucleus is dark or light. If it is a dark nuclei, my first possibility is lymphoid. It's a very closed nuclei, not an opened up nuclei. Like Aishwarya said, this nuclei is definitely opened up. Perfect. You don't see or rods or granules in cytoplasm. I'll come to that soon. Right? So this nuclei is definitely an opened up nuclei. It's not closed and a condensed nuclei, right? When you have an opened up chromatin, which is light blue in color, I think of an myeloid. When you have a closed up chromatin, maybe like this, can I say this cell is definitely darker compared to the ones which I ticked? Yes, that's a lymphocyte. That's definitely a darker cell. That's how a lymphoblast would look. A closed chromatin is for lymphoblast, and an open chromatin is generally for a myeloblast. Fine. Great. I'll erase whatever I wrote here. So I know now it's a myeloblast. Fine. So to call it a myeloblast, when I say myeloblast, I'm thinking of an AML. That's all, right? I'm just thinking of an AML. I have different subcategories of an AML. Right? It could be an AML M1 to M7, anything, right? So Shamail said that he cannot pick up an OR rod or a granular cytoplasm. How many of you guys accept his description? In these cells in particular, are you seeing OR rods or a granular cytoplasm? Do you see them? Do you see any OR rods or the granular cytoplasm here? Actually, no, right? You're not seeing any OR rods or a granular cytoplasm in these images, right? It's not seen. So can I say, at least safely, it will not be AML M3? So whatever someone said is right. I am not seeing OR rod, neither I am seeing granular cytoplasm. So at least it is not an AML M3 because they have bunch of OR rods and very, very dense granular cytoplasm, right? Not an AML M3, right? Okay, that's for sure, right? It could not, M2 and M1 is also a bit unlikely because they also should have granules or a OR rod, right? So those three are ruled out, fine. Okay, great. That's a good catch, Satvik. We'll come to that, fine. So whatever Satvik said, we'll go to the next part. What are these two? What are these two cells? I have two cells here. What are they? Are they eosinophils? Do they look like an eosinophil? They do look like an eosinophil, right? I do have eosinophil. So Satvik said that it could be an M4 with eosinophilia. So M4 with eosinophilia is definitely a good diagnosis. But I'd have been much more happy if you picked up M4 by looking at the blast and not by looking at the eosinophil. But it's fine. It's completely fine. It's eosinophil for sure. I have one more image. Can I say this image is much better and clearer, right? Again, I'm having a eosinophil in the corner. I hope you can appreciate the eosinophil in the corner. Look at this image. If you look at this image, look at this cell. Are you seeing vacuoles here? There are vacuoles seen, right? And if you look at most of them, the nucleus is not round at all. The nucleus is kind of having some or the other indentation like this, right? It's an opened up chromatin. It's having lots of indented nuclei. It's having vacuoles in the cytoplasm. It's not having granules, and there are eosinophil. Can these blasts fit into a monoblast? They do fit into a monoblast, right? That's how a classical description of a monoblast, that's how they look, fine. So this, like Satvik said, it's a classical case of an AML M4 with eosinophilia. I'll just write whatever I described for a monoblast. Monoblast will definitely be huge. Like you saw, it's like 7-8 times the size of an RBC. They'll be very huge. They'll have a very, very open chromatin. As per textbook, monoblasts have something called a sieve-like chromatin or a lacy chromatin. It looks like a sieve. It's very, very open chromatin, right? Monoblasts might have lots of vacuoles in the cytoplasm. They might not have granules, but they have kind of, as per the textbook again, slate gray cytoplasm. They do have a little bit abundant cytoplasm compared to the other blast. In a real life, it will not look slate gray. It might look a little bit bluish cytoplasm, but that's what your textbook says, a slate gray cytoplasm, right? Next, your monoblast can have nucleoli. Nucleoli is plus or minus, you might have them. And the most important thing for me here is the nucleus. A kidney-shaped nuclei is a normal appearance of a normal monocyte. So I might have the retained kidney-shaped nuclei. If you look at this, can I say that this cell does have a kidney-shaped nuclei, kind of having an intended nuclei, or it's an irregular nuclei, right? I can have an irregular nuclei or a kidney-shaped nuclei, but it will be folded. That's the most important thing. It's a folded nuclei. Even if you look at this cell, I'm having a little bit of folding here, right? It will have a folded nuclei. It will not be round, right? That's what I meant. It may not be always kidney-shaped. Even in this, it's lots of folded nuclei, right? You'll have fold in the nuclei. That's very, very characteristic of a monoblast, right? This was a case of an AML M4 with eosinophilia, fine, right? Okay, let's have a quick look about the next case. And ready? So this case, what you're going to discuss, I'm not going to give you any history. Let's assume it's an 5-year-old kid. That might be a little bit history which will be there. I'm going to show you peripheral smear images, and I want you to have the same approach what we generally do for every other cases what you have done today, fine? So just have a look at this image. Tell me what they are. As I said that your first thing should be whether they are neoplastic or not, right? I'll come to the show. My first question here, whether they are neoplastic or not. If they are neoplastic, what comes to your mind? And if they are neoplastic, tell me why they are neoplastic. As I said, this is an image of a peripheral smear. If it's an image of a peripheral smear, can I say that this patient has leukocytosis? That's my first point here. There's definitely a little bit increase in the number of WBs, right? Leukocytosis, lymphoblasts. Second thing for me, the cells what I have here, the lymphoid looking cells, right? So they are blast or not is the second question. As we already know that whenever I think of any blast, I have to look at the size, right? So here, this cell, whatever I'm saying, it's easily twice or thrice or 4 times size of RBC. So I'm having an extremely increase in size cell. It's a neoplastic blast. Perfect. And like I just now said that whenever you have any blast in your microscopy, I want you to compare whether it's a lymphoid blast or a myeloid blast. That's the first thing, right? It's large in size, it has high NC ratio, it's extremely dark. All of you guys accept it's extremely dark, right? So this is an extremely dark and a condensed chromatin, right? So when I have a condensed chromatin, I'm going to think of a lymphoblast, right? This particular question or this case was primarily for us to make sure I'm not having only one finding whenever I see any case. I want you always to have a differential diagnosis. It's definitely perfectly fitting into a lymphoblast. But there's one more classical finding which is seen in the same image. Can you guys, anyone here, look carefully into the smear and comment on the other cells apart from the neoplastic blast, whatever you discussed or whatever it is discussed now. I do have few more cells apart from the blast. When I say few more cells, don't look at the WBCs, not for eosinophils. Rollet formation. We'll ignore rollet formation for now here. Yes, it does look like a rollet formation. May not be the correct site of the smear where I take the biopsy, so I'll ignore for that. RBCs maybe a little bit looking microcytic, that's fine. There's one more classical finding I want you guys to observe. If I look at the background platelets, the number of platelets is normal or reduced or elevated. It's definitely elevated, right? The number of platelets in the background is definitely elevated. It's high in number. If you look at these, I don't expect so many platelets in a neoplastic condition, and some of them are huge as well, right? There are lots of platelets which are looking huge, which are looking abnormal. It's thrombocytosis rather than a thrombocytopenia. I have a good number of platelets here. So whenever you have a blast with increase in number of platelets, keep this in mind. Don't stick to a lymphoid blast alone. Dark chromatin is a classical finding seen in lymphoid blast, but in the background of increased platelets, keep in mind, could it be an AML M7? Again, it's just a clue for me, not always, right? I'm going to zoom into a blast. Look at this blast, this particular blast, and say what comes to your mind. I'm having a classical blast here. It has a very classical appearance. What comes to your mind? If you look carefully, the blast has blebs in the cytoplasm, right? These are very classical blebs here. I'm having classical blebs in the cytoplasm. I have one more image here, right? See, look at this. Even in this image, there are a good number of platelets, right? I have lots of background platelets here, good number of platelets here. They are a classical case of an AML-M7. I do have blebs in the cytoplasm. When you have blebs in the cytoplasm, I want you to think of an megakaryoblast leukemia, which is AML-M7. Right? This was a classical case of an AML-M7. AML-M7 is a rare case. This is the only AML-M7 which I have diagnosed till now individually. So I keep posting these images of the blast with the blebs in the cytoplasm. Right? The very classical case of an AML-M7. Right? So since we have discussed two cases about leukemias, let's have a quick look about what are the salient features for me to pick up a blast. I'll take the query of your buttock-shaped nuclei as well here. Fine. First thing for me, when I take a lymphoid blast, a lymphoblast, I'm going to try the defining criteria only. Will have an extremely dark chromatin. That's the first thing for me. Right. Some of the lymphoblasts, not all, but this might help sometimes in diagnosis because most of the examiners are older. They have a hand mirror appearance. Though the hand mirror appearance has no importance, okay, I'll tell you, give me a second. Right. It has no importance in real life, but this hand mirror appearance is kind of having an more inclined towards a lymphoblastic thing. Fine. If it's a lymphoblast, they will be PAS positive. These are few salient features. They have a dot-like positivity or a block-like positivity. That's one of the things. Second, I have a perfect myeloblast. A myeloblast will have an open chromatin for sure. It will have an open chromatin. Fine. It will have granules. It will have OR rods. It might have very dense granules, sometimes called as phi bodies. Phi bodies are nothing but OR rods is the same eosinophilic granules in the form of a rod. Phi body is the same granules in the form of a big blotch of granules, right? A phi body might be like this. It will not be a tiny granule. It will be a big blotch of granule. That's called as a phi body. Fine. Okay. And myeloblasts, they are positive for two stains. Like I said, PA is dot-like positive for lymphoblast. Myeloblast is positive for MPO. That I would prefer as a better marker than SBB. SBB is, it's not a great marker, right? Third, an AML-M3. The AML-M3, it has the buttock-shaped nuclei. It has the indented sleeve nuclei, that's for sure. So how do I differentiate the buttock-shaped nuclei from a folded nuclei of a monoblast? Because monoblast has a folded nuclei, M3 is in buttock-shaped nuclei. So I'll compare M4, M5 monoblast to M3 simultaneously, right? So one is, when I say AML-M3, it does have a buttock-shaped nuclei. It will be folded. At the same time, the chromatin, though it's open, it will not be like a sieve. It will still be darker compared to a monoblast. A monoblast chromatin will also be folded, but it will be very sieve-like chromatin. It will be completely open chromatin. That's one which helps me to differentiate my nucleus alone of a monoblast from a myeloblast. That's one. Second, the cytoplasm. The cytoplasm has good number of granules, one, and they do have lots of OR rods, which we call them a faggot cell. So it's not just the nucleus. My cytoplasm also helps me to differentiate a folded M3 and a folded M4. M4 cytoplasm will be irregular. It will not be regular. M4 cytoplasm, that's monoblast cytoplasm, will have vacuoles, will not have granules. Fine. Vacuoles, here I'll have granules positive and I'll have OR rods positive. Fine. These both are the difference between an AML M3 and an M4. Fine. This is for M3, M4. M5 also will have more of monoblast, will not have a myeloblast, right? Quick look at M6 and M7. I have AML M6 versus AML M7. Right? M6 is erythroid leukemia, right? If you look at a normal erythroid, you must have read about a few changes in erythroid called as a basophilic erythroblast, or your polychromatophilic and orthochromatic erythroblast, right? Which is the most immature erythroblast amongst them. Basophilic is the most immature erythroblast, right? So leukemia, which is AML M6, arises from the basophilic erythroblast. which means when I have an AML M6, let's assume this is a nucleus. Nucleus of AML, your RBC will be very, very dark and be perfectly round, right? You'll have perfectly round nuclei and a dark nuclei. The cytoplasm is more characteristic for me here. The cytoplasm here will have a bluish appearance because they arise from the basophilic or the most immature erythroblast, right? The cytoplasm blue color is one of the classical clues for my erythroid. Erythroid will always have a basophilic cytoplasm. When I go to AML M7 on the other hand, like we saw in this case, in our case, it might have a high NC ratio, it might have a dark chromatin. That's what we have a differential diagnosis of a lymphoblast. But the most important thing is they have blebs in the cytoplasm. These blebs are nothing but the broken off platelets. They are still mature, leaving out platelets. Platelets are formed by pinching off of the cytoplasm. That's what happens here. Fine. Okay. How to check an adequacy of a platelet? Fine. The subtypes of AML M6A, M6B. For an undergraduate, I'd say it's not much required. Maybe once you become a hematologist, medicine, or a pathologist, you might be required to differentiate AML M6A and M6B. Again, there are multiple subtypes. Even in M4, M5 have subtypes, which is not required for. It's more theoretical, more calculation based, which cannot be done in an MCQ, right? How to check an adequacy of platelets? Because what I said is, when I have platelets more, that is kind of a subtle clue to say it could be an AML M7. Again, it's not always, kind of subtle clue to say it's an AML M7, right? So platelets in general, whatever we saw in this image, can I say approximately for an RBC, I kind of have one or two platelets? Kind of, right? When I see one RBC, literally there's some one platelet kind of in an equal ratio. You know the normal number of RBCs, right? 4.5 to 5.5 million. Number of platelets is 1 to 1.5 to, let's say 1 on the lower end to 3 million. That's 3, right? 3 lakhs. So I should have at least one RBC, or one platelet per 10 or 15 RBCs. If you have something like that, my ratio is perfect. If it's more than that, I'm going to think of a thrombocytosis. But as I said that, CBC will be the best method. The Coulter will be the best method to calculate platelets. This is a rough finding saying that one platelet for 10 RBCs is a rough finding saying, okay, it's more than right. The way to calculate platelets if you're a pathologist, the way to calculate platelets is on an oil immersion. I count the number of platelets and multiply it by 15. Average in a field, multiply by 15, that gives a correct amount of platelets, right? Just as a crude method to say the amount of platelets, right? So we did see about AML M6 today. We saw about few more cases. We'll have few more cases in tomorrow's class as well, whenever we have. And if you are preparing for your exams, you can use these codes. This will give you an extra 2-month subscription. And there are targeted NEET batches. There's a price hike coming at May 31st, tomorrow. So try to grab them. You can use any code, whatever you have. If you don't have one, you can use Pathology, right? Thank you for your time. If you have any doubts, do let me know. If not, I'll call it a day today. We'll try to have few more sessions similarly on pure case-based analysis in the upcoming class. Okay? I hope I've answered most of your queries. If not, do let me know. Okay, great. See you soon. See you tomorrow. Till then, bye-bye. Good night.